Well, I am happy to be here, and I definitely intend to leave, kind of as a bulk of the time for questions, because I think that, as Paul said, if pe for people who joined a little bit early, it's really hard sometimes to get the, time of a physician to ask the questions about how cannabis interplays with mental health. And that's really what we're seeing here, kind of in this day and age, is that although cannabis has had a reputation throughout the ages, some positive, some negative, is that the biggest thing that we see now is what it does to our mental state. So I'll start off with kind of just a setting of the scope of what cannabis is today in 2025, and to give you, maybe a 5-minute synopsis of kind of where we see it from our medical side, and then we'll start to dive into some dialogue about what questions we have and how I could be useful to you guys to be able to help illuminate some of the mystery around what is happening in our society now and why it's so prevalent and we're having such a hard time getting a handle on it. So, when I talk to people about their cannabis use, there's a couple of things that I start with. And one of the most important things is I fact find first. And so I'll ask them, just kind of to set the stage, when you buy cannabis, where are you buying from? How are you getting it? What do you think about what you're smoking? And the reason I ask this is that I have to start to develop the discrepancy. If they think that they're buying, the pot that their parents smoked in the 60s and 70s, then I have to start really from the beginning and help them understand that the pot that they're buying today is not nearly what was there in the 60s, 70s. What they're buying today can be anywhere from 30 times more potent to 300 times more potent, depending on where you're getting it from. But the bottom line is that it is significantly stronger, not even honestly comparable to what was around in kind of that time period of, kind of experimentation and the hippie era. Um, and so I have to help them understand that what they're exposing their brain to is just not synonymous with this innocuous substance that our culture had previously accepted as being what pot, cannabis, marijuana, THC is. So I'll start there, and then I'll get more curious about their individual desires for what they're hoping to get from the substance, because many people share the same kind of myths about what it does. So I'll say, what does it do for you? And they'll tell me that it helps with their anxiety, it helps with their sleep. Some people will say that they don't really feel hungry without it. And so I'll just get a picture of kind of what their impression is of what cannabis does. And then if I see some areas to ask more questions, I'll say, do you ever get really paranoid on it? Do you ever have experiences where you smoked a little and maybe you felt a little high, and then you started to question what was real, what was not real, or people around you started to give you feedback that things were different than you were interpreting them. Because if people really have a kind of one track mind about what the pot or the THC is doing for them, then I have to craft a narrative where we get more curious about other contributing factors to why I'm meeting them in the way I'm meeting them. So I'll start off, like I said, setting the stage about the psychoeducation of cannabis in today's world, talking to them about what they think it's doing for them, providing some information, if they allow me, about what the medical studies show us about the impact of THC on anxiety, on sleep, which, spoiler alert, is that when you do studies like actual looking at measures of anxiety before and after smoking cannabis, it does not improve it at all. Same thing with sleep. When they do sleep studies and they look at it when people have, after they have used THC, the quality of sleep actually does not improve. The time asleep does not improve. What does seem to improve is the subjective experience of sleep, because people are more distracted and disinhibited. They aren't worrying as much about falling asleep and the night ahead. And so they perceive that they're actually sleeping better when, in fact, when you look at the sleep studies, they're not. So those are the ways that I start. But if I also have then come into contact with somebody that I know objectively has had symptoms that go beyond that, the paranoia, the psychosis, hallucination, something that is really, really concerning, then I'll start to have a conversation about their knowledge of the impact of cannabis on that, and really be more clear about the fact that once you have seen those signs in a brain, after it has used cannabis, you really can't ignore it. That is the biggest red flag that you could see for your brain's health, is that if your brain goes to that place when you have ingested THC, you have to be mindful of the amount of times, how much you expose to it in the future, how much you use, because every time you use it after that, you're burning these little connections, and the chances that you could end up with those psychotic symptoms lasting is much higher. The medical literature, as we look at it, we've been looking as a field of the incidence of schizophrenia, a durable psychotic illness, and cannabis use disorders as we've been legalizing, and cannabis has come up in the culture. And although there doesn't show that it has driven up the incidences of schizophrenia, what it has shown is that the diagnosed cases of schizophrenia that also have meet criteria for a cannabis use disorder have gone up. And the thing that has gone up that isn't totally captured is psychosis NOS, which is not otherwise specified, which is when you see psychotic symptoms in a person and you can't figure out where they come from. And they don't fit the criteria for schizophrenia, they don't fit the criteria for other illnesses, but the psychotic symptoms are present. So although we aren't, and I'll reserve the right to say yet, seeing a increase in psychotic illnesses that meet the schizophrenia category, we did just legalize over the last 10 years. And so although we haven't seen it yet, there could be the potential in 20 years that we do see it. It just hasn't been a big enough effect yet. The last thing that I will say, and then maybe we could start to kind of have a dialogue and that'll drive the rest of the conversation, is the treatment for cannabis use disorder and why it is so troubling. And there are a couple of things. One is, and I struggle with this all the time with adolescents, young adults, is when we are telling that age range, you can't smoke pot, but their parents still do, but everybody around them still does. But it's normalized for other people. But I'm sitting there saying, you can't do this, right? And so that is, or that's how it feels to them. I don't approach it in that way, but it is really, really isolating to tell somebody that something that has become very socially normative is not available to them. So part of the treatment has to be about developing their sense of worth and how they can feel connected to their peers, to their parents, to whoever else it is without that. The other thing is that, unfortunately, insurance companies don't think cannabis use disorder is that important. And so unless there are contributing factors, they don't reimburse for rehab stays for just run-of-the-mill cannabis use disorder. And so we have to get crafty as a profession of really illuminating what else is going on for that person and why they should meet criteria for a controlled setting. Because it is important to be able to offer them the same treatments that we offer for other people with different substance use disorders, which is rehab. And there's there are reasons why rehab works for this. But because the insurance companies don't realize it in that way, it adds another hurdle for us for offering treatment. The thing that I will say, the last thing that I'll say about the treatment, and then we could start to have some dialogue, is that the biggest struggle with cannabis use disorder and why oftentimes I do think they end up using rehab as a tool is that it's very, very hard to spend, for example, an outpatient, even if you're doing an intensive outpatient program, 3 hours a day, learning the skills, building, building your armor, and then going out and having, walking by someone on the street that's smoking pot. It's everywhere. It's not even just like drinking where, you don't go to the bar. It's not, this could literally be on your street corner as you're walking home. And you can't always, get away from people, places, and things because it's actually everywhere now. So sometimes rehab offers you, the contained setting of being able to have your brain switch from those cues in a way where you start to make different connections. I am also seeing one, yeah. So somebody did mention that there a European study that showed the increase in schizophrenia for young males. So young males are the population that we are watching the most. And there is the high potency THC is also the thing that may tip the needle. But it hasn't been, it's hard when it's not replicated in multiple studies. It's hard to say that it'll end up being a trend, but that's why I say that I'm hinting at wait 10 years and we really might see a trend. But the young males and the high potency is our biggest concern. But what, I'm open to kind of taking the discussion wherever kind of people have questions about, or we can, someone's asking what I mean by high potency. So the high potency is the content of THC. So back in the day, the content could be somewhere, maybe three something percent. It's well over 20% now. So there are two chemicals in cannabis. THC, which is the one that's psychoactive, which is the one that goes into the brain and hits the dopamine and can create psychotic symptoms. And then there's cannabidiol, which is supposed to be neuroprotective. And we do in addiction use it at times to look at how we can take the edge off for other substance use disorders. So, for example, there are studies looking at CBD, and you see the CBD oils everywhere, but CBD for like opiate use disorder, things like that. But what these dispensaries do is they're showing you the ratio of THC to CBD. And if you look at them, the ratios of THC could be upwards of 20%, which is pretty dangerous for the brain. And the CBD is actually lower. And if somebody really were looking for what has medically been established as a calming effect, that you'd actually want more CBD because it has been shown to be a little more neuroprotective. I see Laura's raising a hand.
Oh, sorry.
Go
I
ahead.
have a question. In terms of the THC induced psychosis, is it the kind of thing where you either really have a predisposition for that or not? So you're either like sort of biologically predisposed to demonstrate those symptoms or not, and so you may never, or is it the amount of THC that might tip the scale on that?
So that's the thing is that yes, genetic predisposition is one of those easy ones to say this could be really concerning for you in particular. You should be really careful about your exposure. However, with this high potency cannabis, it's almost kind of overriding it. So although it would, for somebody that I know has genetic loading, if I could, have my magic wand and I would say, I would hope to, with somebody with genetic loading, never expose them to cannabis because that is one thing that you sometimes can't unring the bell. Once they have that exposure, it sets off a cascade that maybe would have happened anyway, but it happens earlier. It happens, sometimes more chaotically. It becomes something that we're battling like both the things. We're battling the patient's attachment to the cannabis because it does quiet the noise for them for the moment. They don't see the connection that it's making them more psychotic. They get distracted and disinhibited and calmer in the acute intoxication stages. So they want to use it, but it's actually making everything else worse. And so, and once they become psychotic, sometimes they lose that insight and the ability to reason. And so then you have this three-pronged problem where they have the psychotic symptoms, they think the cannabis is helping, and the psychotic symptoms include a position in their mind where they're pretty rigid and unmalleable. And so it becomes really problematic. So if I could make an effort somewhere in the world to what we would do for how we would address cannabis use, it would start so much earlier with parents of middle schoolers, probably to educate those kids about how to amplify their success the best they can. So if they had a genetic loading, not to stigmatize it, but to just say, hey, so and so in our family has this, we have this in our family tree. Everybody has something. Everybody has diabetes or whatever it is. The thing that you can do to protect yourself from being somebody that would develop this is stay away from cannabis. I know that all your friends are going to do it, but for you in particular, it could have much more impactful consequences than it could for some of your friends. But it has to be started early and destigmatized in a way where it's not like, ooh, you have somebody with, schizophrenia in your family. It's no, you know that you somewhere, it's like telling somebody that they have people with peanut allergies. You're going to go eat a bunch of peanuts. No, we listen to that, but this we don't. Um, so that's kind of how I would address that. There's also a question in the chat about harm reduction counseling for cannabis with regards to the high potency and asking, for example, would you counsel by switching modalities? Vapes are so dangerous because you have no idea the quantity. They do it all day long. It's next to their bedside tables, and they really just it becomes almost routine. So I think that vapes are problematic, but in terms of harm reduction, if somebody was going to be permissive about how they were going to allow them to use cannabis, I would say the thing to look for is that if they were going to get it legally from a dispensary, look for that lower content THC. Um, because if you're buying it from somebody, you have no idea what else is in there. You have no idea if there's fentanyl in there. You really don't know. And the vapes become so problematic with how often and accessible they are that it typically does up it. But I wouldn't recommend just switching to a different modality because you still don't know what they're putting in it. So smoking a joint of high potency cannabis is worse than vaping all day long of low potency cannabis, if that makes sense. Um,
Hey, Amy, I'd like to, just say that it works pretty well for people to just unmute and
mhm.
ask, especially, if it's a little bit more detailed about an individual loved one.
Yeah.
So I don't know
Yeah,
if
they can't. I would,
Kaya, do you want to talk up and just explain
yeah.
situation?
No, 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 it's okay. Not at this time.
Well, I can, how about, do you want me to just summarize? Because this is what you've written in the chat is something that probably resonates with a lot of people. Do you want me to kind
Yeah,
of
sure.
Okay, so somebody that has been diagnosed with cannabis-induced psychosis, which again, it sounds like this is a case where it's like it's not necessarily schizophrenia because it doesn't meet criteria, but there are durable psychotic symptoms that have lasted. And oftentimes I mean, regardless of what caused it, when we see psychotic symptoms, we prescribe antipsychotics. Um, the Anytime somebody is acutely psychotic, we prescribe a higher dose of medication than they may need in maintenance. If they are, if they have cannabis-induced psychosis, the psychosis completely resolves with a dose of medication. What I recommend, because the hardest thing to do is stay on these medications long term, and they may need it, they may need that glue, is getting down to the lowest effective dose. So if they're not, and this is what I say to them when we are treating them, I'll say, listen, stay on this dose for 3 months. If you don't smoke pot again, I said, in 3 months, we could look at maybe we'll take down a couple of milligrams at a time and see how we do. I said, the biggest opportunity for me to get you on the lowest dose possible is for you to join with me in this and not smoke pot because I know if I'm trying to get this boulder all the way back down the hill and you're smoking pot and pushing it back up, we're going to end up on a standoff. So if you're not going to smoke pot, I can definitely try and get this lower. And having the close enough follow up, if you start to see little psychotic symptoms creeping back up, then you agree that we'll have a collaborative conversation about just finding a dose that's stable, that may be there for the rest of your life, but works. Oftentimes I have a conversation with people about, they'll be like, I don't want to be on something for the rest of my life. It happens around Suboxone or the antipsychotics a lot. And I say, listen, when somebody's diagnosed with diabetes and we tell them they're going to need insulin for the rest of their life, nobody balks at that. They take it. They figure out different ways to take it. Um, it's understood that if this is a necessity for functioning, this is what I'm going to do. But there still exists stigma around some of these medications for psychosis, for substance use. And so we, as like in the medical profession, really have to pair with the patient to destigmatize that. And then oftentimes it involves the family too, because families typically struggle with it just as much as the patient does. They say, I don't want my loved one to be on this med. I don't want them to have to take something for the rest of their lives. And I often liken it, and anyone that's heard me talk before will say this. I say liken it to contacts. I get up in the morning, I put contacts in my eyes every day. And it's because I want to see the world a particular way. I want to make it easier to function in the world. Could I walk around without contacts and not, have my sight be blurry? Sure. Would it be dangerous to do certain things without my contacts, like drive? Definitely. It is a choice I make every day to allow functioning to be the easiest possible. And that's the same way I classify some of these medications. So if a loved one has cannabis-induced psychosis, is on an antipsychotic, and it works for them, find the lowest possible dosage, keep it going as long as it's working for them. What other questions do people have? Paul, I know you have a bunch loaded, so feel free to jump in whenever.
Let's see, did somebody, oh, that was a thank you. Could you just address the issue of, so somebody comes in, they have co-occurring disorders, so you have to address both at once.
hmm
And then using the medications for mental health while someone is still using, that's problematic. So it's delicate. So I'd just like to hear how, somebody that comes in to Silver Hill and, you'd go through detox and how you can address this?
Well, so this happens every single day. The first thing I do is that I tell them that I'm not sure if they have a previous diagnosis and it's definitely well documented and, I've got collateral information that it's 100% this, and fine, I'll kind of accept that. But if many of these patients come in with bipolar diagnoses because substance use and acute intoxication does mirror mania at times. And so if I'm not sure what the person has, but I do see symptoms in front of me, like I just described, I'll tell them, listen, I am going to prescribe this medication to address this medication to address that. And if they are not, acutely psychotic and they can kind of describe to me what was happening before, which is why they potentially contributing to why they were choosing substances, I'll find a strategy to try and address that as well. So they may come into me looking acutely manic because they do have an underlying bipolar disorder and it was exacerbated by excessive cannabis use, but they were using the cannabis to control what they perceive to be anxiety. We'll tackle all of that together. Oftentimes, what I'll find is that there are a couple of things that do lead to an uptick in substance use. One of them being, if there is an underlying bipolar disorder, whether it be bipolar 1 or bipolar 2, somebody that may have bipolar in their family is typically bipolar 2, but then they used some really potent THC and they look bipolar 1. I'll tell them, listen, like I'm not going to put a diagnosis on this right now because I do think that the snapshot I'm seeing is being impacted by the recent use of substances. So let's see what you look like in, a month or two of sobriety and see how we can discuss what would be a recommendation for long-term maintenance. Because depending on what the disorder really is, depends on what I'm recommending as follow-up care and how much meds and all of that. But also, it's really important. Why did they seek the substance to begin with? Because if it is some mood state, then I have to address that too. If it's overwhelming anxiety and that's why they're smoking a ton of pot, then I've got to help them manage anxiety. So it really has to be looked at why they're using what they're using, why I'm seeing what I'm seeing in the time I'm seeing it, and hopefully by the end of their stay with us, making a recommendation for what the next year, for example, timeline should look like. Kind of in multiple different scenarios. In the best case scenario, without the contribution of other substances, in the scenario where they're using sporadically, or the scenario where the use returns to what it was prior. And then I'll usually give them and family an indication of kind of what to do then if use does not stop and it is still impacting mental health.
I asked this before about ADHD, but maybe that before everyone was on. But if you could just address that, do you see that a lot
So we
in
see it all the
your
time.
practice? Yeah.
ADHD is really difficult to live with because you feel less than functional. You can't finish tasks, you struggle at work, you struggle in social situations sometimes. And the biggest problem for getting or barrier to getting ADHD treatment is sometimes co-current substance use. People don't want the medications that we use to treat ADHD are stimulants. They have street value. They can produce psychosis themselves. So if, for example, you have a cannabis-induced psychosis and ADHD, I can no longer give you stimulants. I have to work with a non-stimulant option. So it becomes quite difficult and my options get more limited. So what I tell people is that if you achieve sobriety in a way where you are now a candidate for other medication options, that it opens up the ability to treat the ADHD better. It doesn't mean that I would never give, if somebody doesn't have psychotic symptoms, there are no contraindications. I could give a stimulant to a person that has a substance use disorder. It's just the way I give it is different. I might give them smaller supplies. I might limit dosage, so that there is no value in abusing or selling or anything like that. And I reserve the right that if, we have a kind of contract and how we're going to work together and they violate that, then I'm not going to give them stimulants again. I'll give them non-stimulant options, but I can't use that tool anymore. But there are just, the problem is that the medications that are used to treat ADHD are limited by if you have psychotic symptoms, you cannot use stimulants.
Could you give an example of someone that comes in, they have they have co-occurring issues, but they have a significant cannabis use disorder. How long are they in inpatient or detox?
I have one right now. She came in and I met her and I felt so sad for this woman and I was about to call her a girl because it felt so childlike when I met her, but she's in her late 20s. And I actually don't think she would have ever come to meet us in the way she was if she wasn't smoking cannabis. She has a family history of undiagnosed bipolar disorder, but the way they describe some family members definitely meets criteria for bipolar 2. Um, she had a chaotic and kind of traumatic upbringing, just a lot of just kind of risky, probably ADHD, just like a lot of impulsivity, risky decision making. She got sober from alcohol 4 years ago and she replaced it with cannabis. And has been smoking cannabis densely for 4 years. I brought her into inpatient and I started her on Risperdal, high potency medication. I wanted to quiet the noise in her brain. I could tell she was disorganized. She couldn't tell me, I'm asking her for a timeline of life and she can't tell it to me. And so, but I know she wants to. It's not because she's, being deceptive. And so I started her on the Risperdal and I could see a week in, I knew it was working. It was improving, but I needed her to not smoke pot again. And she had some other stressors and things that could be improved. And so I was like, listen, I get that you don't want to be here. You never intended this. And would you consider one of our residentials? Because two things, I want you to be able to work on that interpersonal distress. And I need, she'd voiced to me that she saw how much clearer she was without the cannabis. I was like, I need you to really solidify that desire right now. Like now I have motivation. We have to go full steam. So we applied and we got her patient financial aid, which was incredible. And she is doing the work in the residential without the cannabis. She's still on the Risperdal, and she's still continuing to get better. She was really paranoid when she came in, but she was smart, so she was vague about it. So I think it's going to take her a full 5 weeks to really have the idea, and I'm going to leave her on the Risperdal. I'm going to lower the dose, but to have the stronghold to keep the impacts that cannabis had at bay. But cannabis doesn't tend to leave a lasting psychotic syndrome unless there was some other ability for it to produce that. Some of the other drugs like meth, crystal meth does. Um, but if cannabis does leave that kind of durable impact, then I know that I probably need to pay a little bit more attention and keep them, longer so that I can make sure that I can. I explain it to them like it starts this little fire in your brain. And when I give them meds, the fire starts to, comes down to embers. But if you don't, it's like, you can't go to sleep with embers in your fireplace. Like it's dangerous to leave them there unattended. I have to make sure that they are completely turned to soot before I, kind of walk away and say that this episode of illness is complete.
You just gave a perfect example how every patient is different. And even if they all have cannabis use disorder,
Yeah, no, I mean, it impacts it. It's very, the way that I have to approach it with each patient, I have to be dynamic. I can't, and I can't prescribe sobriety to them. I can't come in and say, you have to stop smoking pot because guess what? You tell somebody to stop smoking pot, one thing they're going to do is going to go prove you wrong. Say, I can smoke pot. This is going to be fine. So I really just have to craft conversations so that they are providing information about why the cannabis that they initially thought was helping them is more problematic. Um,
if we just take away if we just narrow it down to the cannabis in the system after a month of sobriety, it can't, THC is completely out, correct? But then people talk, and even in our support group meetings, how it really took a year before their heads were, their loved
it's
ones' heads were clear.
Well, it's because it's like this. Think about this. You burn down a forest. You're going to see that lasting impact of that fire for months, right? It takes time for the vegetation to grow over it. It doesn't mean that it didn't, the mark still might be there. You might see these things that you could find from fires years ago. But if you put enough regrowth opportunity back in, then the lessens the impact of it. But it really is impressive how much it changes the connections we make. One of the things I just did this series at Darien High School, presenting for their drugs and alcohol, for their extracurricular activities, that they have to attend a drugs and alcohol session. And one of the things that I think is the most important to impart on people is that the decisions that we make now impact our brains later. And the reason that many adolescents and young adults use cannabis is to connect with others. But what it actually does when they look at studies is it inhibits your ability to read the emotions of others. So even though you think you're doing it to join, it's actually in your brain chemistry prohibiting you from reading the human around you, which is the exact opposite of what a lot of us want to do. Um, because all we want to do is fit in, most of us. Do you want me to answer a couple there's two more questions in the chat. Shall I?
Good.
It says, how are you teaching med students and social work students about cannabis use disorder and psychosis? It has to just be explicit. We have to, whenever I get the ear of, in my previous life, I was teaching a lot because I was program director also for our addiction psychiatry fellowship. I worked with med students, I worked with psychiatry residents, and if I don't educate others about this, then they won't be educated when patients talk to them about it. So I try and give them any chance I get, give them, a little bit of a framework for how to open conversations about patients' cannabis use, how to approach it non-judgmentally, and how to develop discrepancies between what the patient experiences and likely what the actual impact of the cannabis is, because the patient experience is typically on first blush, they're going to be like, no, it's great. It calms me down. It's the only thing that helps me. And I'm sure all of you have heard that narrative before. And so it's about feeling confident how to direct the conversation so that you can actually elicit statements that are probably more truthful about really how it is contributing to negative emotional states and potentially psychosis. And then the other one is, do you ever recommend an herb or over the counter for a 23-year-old who's been smoking vape daily more than one times a day, who wants to stop but is worried about withdrawal? So the anxiety about the impending withdrawal is typically the thing that keeps people going. I will tell you this, cannabis withdrawal, it lasts, I don't know, depending on how heavily you're smoking, 10 days to a month of actual withdrawal symptoms. It's the things that are all kind of the opposite of what we think cannabis intoxication is. So it's insomnia with vivid nightmares. It's, poor appetite, irritability, kind of that agitation, but it's not medically dangerous. So if somebody is truly motivated and is intending to stop using the substance, it's going to be about breaking the behavioral attachment to it. So developing a skill set to tolerate that distress and the negative emotional state will help them. If we just replace that with something else, then we're not breaking the behavioral pattern and they're still going to feel stuck in a cycle. So what I would recommend for somebody that is smoking, is vaping daily and has motivation to stop is really seek the support of something structured to help them break the behavioral cycle, but also find a place for the grief of what they were probably seeking, using it to quiet some other distress or emotional state. And so finding a way to feel empowered in their taking their kind of choice back of how they're going to manage their emotions, but not feeling panicked that the emotion's going to overcome them.
Thank you. And I know we have a couple, at least a few recovery coaches on here, so they usually are asking questions or speaking up. But I do want to leave it open that if people want to just put their questions on in the chat, that's fine.
Yeah. Somebody else just said that their loved one has bipolar disorder and that mania only grows after smoking pot. Can a diagnosis of bipolar be made when THC is present? In cannabis-induced psychosis, would you expect a period of depression after the mania or psychosis has passed? So the first question, that's where it gets tricky. A lot of people are going to be diagnosed as bipolar disorder. Once you see mania, mania is mania, and our DSM does not exclude if it's only present or exacerbated by cannabis use. I wish that there was a category for cannabis in exacerbated mania or cannabis, to account for the contributing factor. Regardless of that, though, once you know that cannabis makes someone manic, I think there is a utility in identifying a bipolar disorder because every time somebody is manic, their brain is on fire. And so if we are having a shared conversation about this person's brain could be on fire, then we could take as many preventative measures to keep that from happening. So that's why I don't hang my hat so much on the diagnosis, just on what we need to do to make sure that the symptoms don't inhibit functioning. So I would say that if mania only happens after cannabis, what I honestly, treatment plan wise, what I would recommend is obviously stopping the cannabis use if possible. That would be my biggest push for how to achieve wellness, but also keeping a mood stabilizer on board for a period of time until cannabis use really has stopped. Because if you are going to accept that somebody may not be completely abstinent from cannabis, then you want to prevent that fire from starting to burn and taking down things around it. For cannabis-induced psychosis, would a period of depression be expected after the mania or psychosis has passed? Not always. We do typically see depression after organic mania that's not been contributed to by substances, but when we've lit that match and we see it, sometimes it goes out quite quickly and they feel restored. But if there is a true underlying bipolar disorder that was just uncovered by cannabis, we will usually see a low mood, a low, period of low mood. It's like being in an 80-degree pool after you're in 100 degrees. Normally it wouldn't feel cold, but because you were just sitting in that 100-degree pool, it feels pretty cold.
I love your analogies. I love that fire analogy. That's great.
If anyone that's known me in my former life knows, I mean, the analogies, they just come, I feel like it's a way to help people understand more because we can all think about them more, like the imagery a little bit better. And our brain is so important. And I want people to cherish what they have and protect it.
Dr. Swift, my name is Jack Clayton. Can you hear me?
Yeah, I can.
I've heard of you. I work with a recovery house or a sober house in New Canaan, and um, I've been recovery coaching a gentleman for a while, and he has a son that's had, I think, a long duration problem with THC addiction. I don't know about the underlying issues. I know that he had spent, I think, a year under term bridge care. He's probably in his early 30s, and there's been some family issues, that sort of stuff. But, a few weeks ago, uh, apparently the son had started to resume using THC again, and nobody noticed it, and nobody was monitoring him.
Yeah.
And, I'd observed him for perhaps a year. He had finished with term bridge. He was working at Goodwill,
Hmm.
kind of like, kind of assessing donations for value, and he was trying to get into a better position as far as his future employment. Very nice young man, but then I guess, as a result, perhaps of resuming the THC usage, he ended up kind of having a psychotic break. He went to, I guess I used to call it Holbrook. I think it's St. Vincent's in Westport,
Yeah.
where he did detox um, and I saw this boy last night at the lighthouse, and he's really just kind of in a very protected state. He doesn't talk, and he's actually going to be leaving next week to go to a farm up in Vermont where they
Mm.
treat folks like this, and he may live there for a year or something. And now I'd seen him periodically while he was not using, apparently, and he had a job and he was looking to be upwardly mobile in his employment, and he seemed like a nice guy. And I'm just wondering if for that period when I knew him when he wasn't using, like if he didn't use again, might he have been okay and not had a resumption of this psychotic stuff? Or
Yeah.
is it all, or do you have to assume there's something underlying that anyway that's a big problem that needs long-term
Well,
treatment?
hearing the case, I think that there probably is something underlying it, and I think if he never smoked pot again, it wouldn't have potentially bubbled to the surface to remove him from his surroundings. Um,
Okay.
Meaning that like you can't have cannabis can't impact you that dramatically without the right opportunity. But if he had stayed kind of in his routine without seeking the cannabis, then even if he got a little bit psychotic, if a little bit of something happened, potentially it would have been identified early, maybe even dampened in the outpatient setting, and then it wouldn't have disrupted his life so dramatically. The other thing I will say though is that if he was able to stay away from cannabis for so long, I wonder if he had some return to symptoms that led him to choose something distracting, like a maladaptive coping skill for something that was cropping up anyway, which remains, is potentially a possibility, which is where the therapeutic alliance is the biggest thing. Like our relationships with our patients is where I put most of my effort because if they don't believe that I'm here to help them, they're not going to take the meds I'm prescribing. So my meds, the medication regimens I use aren't, those things aren't, that's not where my intelligence lies. It's about building a relationship with the patient where they believe that my authenticity in desiring to help them exists. Because that's when they'll come
Well,
to me.
yeah, no, well, thank you. And this is above my pay grade, but my sense was, gee, I didn't understand maybe why he couldn't do an IOP and kind of get back to the routine that he'd been in when he was being successful, since he's not using now. But he's hasn't snapped out of whatever he
Well,
felt like
right.
you know.
Yeah, there's probably low level psychotic symptoms that are still there and they just want to put guardrails up so that the cannabis can't impact it anymore. you
All
know?
right. Well, thank you very much. I
Yeah,
appreciate everything
of
tonight.
course. Leslie has a hand up. Go for it.
I just want to say that I'm somebody that gets contacted by a lot of families from across the country, both via my work with the Treatment Advocacy Center and with my work specifically in Iowa. And I'm also connected to a huge number of families that are in the cannabis-induced psychosis private support groups and that kind of thing. And I think you are underestimating the number of people that are ending up with actual bipolar disorders and schizophrenia from cannabis who had no family history of mental illness in their families. The numbers that we talk to, I
So I
think
think
would blow you away.
no, I actually I agree with you. I believe you, but looking at the medical literature, they don't see it yet. The controlled studies looking at these populations, they're not capturing it. I see it every single day. Every single day. But it's not, if you look it up, like if you were to go to PubMed, which is like a kind of our, our search engine for physicians, and it doesn't capture it. But it is, you're 100% right. Every day I talk to them and they say, but I don't have, nobody in my family has this. I say, well, guess what? They're not smoking the pot that these people are smoking now. Like that, maybe there would have been something, but in the 60s and 70s when they were smoking this, it wasn't nearly as incitatory as what we have now. And this could find the tiniest thing, the tiniest vulnerability, and bring these symptoms out. But it's not necessarily a family history of mental illness. It's just some, unfortunate constellation of connections in the brain. But yes, I believe.
Okay. Well, I guess I just would say I respectfully disagree. And I think that we have a responsibility in warning all children and all people that there's a huge increase in the prevalence that we're seeing, regardless whether or not you believe that the medical studies are bearing that out. More
Yeah.
and more studies are coming out all the time showing this.
Yeah, I know. I agree. I wish, the reason that I say it with caution is that when I say it, people go and they'll pull up the studies and they'll say, this isn't what it's showing. And I'm like, no, I know. I could pull those up too. These are studies published in 2025 or studies done in 2022, right? Like there's such a delay. But I don't want to ruin my credibility by not having somebody, by having somebody kind of show a study in my face because you're right. That's what I said. In 10 years, I think that our studies will show exactly what you're saying. But we're just not, we don't have it solidified in, kind of our medical Bible yet.
Susie?
I'm here for it when it is.
I have a quick question. So my son just came home from college. He's been sober about 2 weeks. He's already done rehab and sober living for alcohol and cannabis use a year ago. And his current doctor, his psychiatrist, has said that in terms of his co-occurring, he has anxiety, ADHD, depression, you name it. Mainly anxiety is his biggest challenge, I would say. He is saying right now that he thinks that he needs to be sober for a period of time before they address a lot of his co-occurring. And what's confusing to me is what
It's a
I've
myth.
learned. Yeah.
It's a myth. You can treat them both at once. We can't, here's the deal. I can't tell you if the anxiety meds work yet. But it is worth a shot. I mean, I wouldn't give a bunch of benzos because those have other addictive,
Yeah.
you know, but I would absolutely, if there's no family history of bipolar disorder, start an SSRI. That is what I tell people about how SSRIs, which is our first line for anxiety, work, is that I say you start taking it and you feel nothing. You go 4 weeks, you get to a good dose, and you look back and you realize that days are a little bit easier. The bad days aren't stringing together in the way that they were. It's like going outside in the cold, but now you have a winter jacket on. So
I'm sorry to interrupt you. He has prescribed him. He's on Vibrate. What he's saying is that and I know it's new.
yeah.
And I know it's new, so the jury's out probably a little bit on it. But he is more saying that he thinks in terms of therapy. Like I think he has OCD.
Oh, he could do therapy.
Right.
OCD is one of the more underdiagnosed things that is incredibly disruptive,
Yes.
disruptive to functioning. And if it doesn't look like counting, stepping, all those things, then people ignore it. But yeah, I always think therapy is low cost, high yield. If
Yep.
you do it and the person's interested in doing it, it actually changes the neuroplasticity in our brains the same way meds do. So there's
Mhm.
really no value in not doing therapy, honestly.
Okay. Thank you.
Of course. There were a couple of other questions in the chat. Somebody was asking about high potency, a young adult son, high potency THC around the clock, and reporting that he's self-medicating for ARFID, ADHD, insomnia, anxiety. because as a teenager, he couldn't get kind of his needs met from the doctor and therapist. Um, and is asking for someone like this, is it reasonable to consider medications to address the underlying issues to support movement towards recovery abstinence when he's ready to consider reducing or quitting cannabis, but he's not right now? I would say find a therapist. Just from the middle of that, saying that the doctor and therapist didn't listen to him means that he needs a better therapeutic alliance first to develop a conversation where he's curious enough to explore recovery or abstinence. It feels overwhelming to do it when you don't think you have the support to do it. Because obviously, if he felt like he had the support as a teenager, from his physician and therapist, and maybe he could have addressed some of these other things, but he's now stuck in a cycle where it feels terrifying to get off that hamster wheel, because you don't know, it's an abyss. You don't know what's going to be on the other side. So I think that finding somebody that is open to a discussion in terms of harm reduction first, and then they could develop a discrepancy of what this is doing for the symptoms that he's experiencing. There's another question about genetic tests that can capture a family history of mental illness. No, unfortunately. When people always ask us about all these objective tests, there are some things that we can capture. The best test for us is a thorough interview and being able to ask things that are not just, do you have a family history of bipolar disorder, but describing behaviors, getting a real authentic feeling for what the family was like and how it's been to grow up in that family, because then I can start to understand when there are characteristics that I am seeing contributing to what the person in front of me is experiencing. And then what is the best way to support a college student that has been through multiple IOPs and a therapist who's working on harm reduction? Unfortunately, college is a difficult time because of the peer influence. It is the time where people look for their peers for how to, they're no longer looking to their parents for guidance. They're looking for that peer group. And in our world today, although many in that age range have started to drink less than we did in those ages, cannabis is everywhere. And so it really is about having sometimes patience, because as their brain develops, they make better choices, but B, allowing them to try again. I never tell somebody no on rehab, if they have authentic intention and it's not for something, a cause that, hiding out from, a drug charge or owing money or something short of that. Like it's any rehab could be the last one they do before they achieve sobriety. You don't go to the supermarket, buy food and let it spoil and say, okay, I'm never going to the supermarket again, right? Like you can keep trying and seeing if you can put things together in a different way so that it makes sense. But I think having that college student be able to find their people where they still feel a part of things and can normalize the behavior or intention that they have, will help them build their self-worth that doesn't involve fitting in that group. But I do think, just the more eyes on, but like I said, IOPs are really hard for cannabis because cannabis is everywhere the second you leave. So it just continues to, cue the brain in a way that even if you're not intending to, it just, it's sending the signal.
You yourself use the word harm reduction. It can mean so many things, and certainly the loved ones like to use it really to manipulate their parents into being able to continue to use.
I say it in that we have identified goals for our loved ones, and that's fine. That's normal. But the biggest mistake we could make is not allowing them to share their goals with us, because if we can find somewhere in the discussion between their goals and our goals some common front, then we have a way in. Then we have something to join on. So even if they're saying, I want to smoke pot, and you're saying, I don't want you to smoke pot, but we both want you to feel less anxious, let's join on that one and let's figure out how we can work towards that path. Because maybe somewhere down the line, our interests will align in a way that is productive. But I think that, harm reduction is a tough term in this space. Some people hold it as this like, this new thing that we do. No, it's meeting the patient where they're at. I can't I can't prescribe abstinence. I can't prescribe sobriety. I can inspire it. I can try and help somebody find a path towards it, but it has to come from within them. And so when I think of harm reduction, I think of when I'm looking at my goals for a patient and their goals, I'm trying to find a way to make the impact of whatever is happening now the least dangerous possible, and always keeping the conversation open to hear what they have to say, because the second I quiet their narrative is the second I lose the ability to have any insight into how to help.
Is that motivational interviewing
And
and what?
yeah, motivational interviewing is basically all I do with patients, like psychotic, not psychotic, patients with substance use. No, it's just I think, a more collaborative way to interact with patients. It gives them a conversation. They join the table. They're sitting with us. They're talking with us. It's not a question and answer. It's pretty much the only way, and I've taught it for so many years. Like I literally have the whole book basically memorized and outlined. But it allows people a seat at the table. Um,
Silver Hill is known for the DBT work. Are there any other acronyms or initials you'd say are important for in the cases with THC addiction?
So THC addiction, because of the political climate around it, it becomes a little bit tougher. It isn't something that no one else is going to throw research into finding modalities to treat it because people are also putting money into it as an industry now. So I honestly think the tried and true, finding the using, you can use DBT. The distress tolerance piece is huge because that's where most people are seeking THC, is to move away from some distressing emotion. Um, but the motivational interviewing DBT, though, they do work for somebody that has a time limited thing, contingency management. So for a pregnant patient, it is worth it to do something like that if there really is a potential to impact. There is a question about MAT for someone with cannabis use disorder. If I'm not worried, if I'm doing it and I'm prescribing it, and our team is doing it in an inpatient setting, sure. If you want to give them a little benzo to help them get through the insomnia, no big deal. If you know you're doing it in a time limited way and you're not creating another problem, would I do it as an outpatient? Probably not, because I don't want to set them up to fail. But inpatient, when they're with me, sure, no problem. We can absolutely figure out a comfortable way to get through this if it'll help you get to the other side, which is where you'll start to build the skills to not use again. Um, and then there was another question also. It says cannabis should remain legalized. However, what are possible legislative avenues for reducing harms of cannabis? I mean, I honestly, that question stumps me because as long as they're upping the content, it's like lactose. It's going to be bad for some people. I can't comment on whether or not, like, what they should do with it, but for some people's brains, it's just going to be a problem. So I don't know, because it isn't a generalizable thing. I don't know that there's a way to make a legislative avenue about it.
You can reduce the potency, but the
We
problem with that is people can buy it in the black market. So
But that's the problem, is like, you reduce the potency, are you pushing people to the black market, and is the black market now doused in fentanyl, right? Like, what's the long-term effects of it? It's a question that honestly is above my pay grade in terms of what to do, because the last thing I want people to do is be going to buy moonshine, like, essentially is what happens is, like, we outlawed alcohol and then people bought really dangerous alcohol. There's also a question about the difference between psychosis and mania. Mania is a mood state. Psychosis is a set of symptoms where somebody has a departure from reality. So mania is where somebody's could be incredibly irritable, have an elevated mood, they're grandiose, they think better of themselves, but it often ties into psychosis where they aren't based in reality. They may have delusions of who they are, their importance, things like that. But a couple of objective things of mania: they have less sleep. They typically look revved, just like physically. They're moving around a lot. And you can actually see it. They blink less too, which is one of the objective signs. It's pretty interesting. And Leslie added also, we could recommend potency limits for selling it. Yeah, absolutely. I mean, absolutely. Absolutely. I think the legal age should be 26. The brain's not done developing until 26. Why are we giving it to them at 21?
That was a
But
compromise with the legislators.
I know, but come on.
I know, I'm with you. I'd go to 30.
Yeah, literally, I mean, why not? That's my mentor when I was training said that if he would feel successful as a parent in life if he could keep his kids away from cannabis till they were adults. Um, and I think that that's the right message, right? Like, make a choice with your brain being as developed as it can be.
Mm-hmm. I agree.
And any other questions? Because the doctor is in session for just a few more minutes. Um, this has been great. I mean, I would just say one thing that is frustrating. There are many rehabs out there that specialize in alcohol use disorder. There are many 12-step programs for alcohol use disorder, but it's hard to find a support group for marijuana. There's some online, correct?
But I wish that we did it more. I mean, I have a middle schooler right now, and like this is the time to start developing the conversation. Teach them how to say no now. Teach them how when it's so it becomes a muscle memory. I would love for them to have the skills to be able to apply it when it mattered. But it's like I feel like it's like the safe sex. Like we think if we give them condoms, it's going to make them have sex. It's like no, give them the condoms. Sorry, go ahead, Leslie.
Yeah, just in case you're not aware, there's an organization called Johnny's Ambassadors. Do you know of it?
No, tell me.
Oh, it was founded by Laura and John Stack, who lost their son to a cannabis-induced psychosis, suicide. But they go around the country speaking at middle and high schools about preventing the use of THC. They have an amazing website with a wonderful research library. I'd encourage you to connect with them at some point.
Yeah.
They are doing amazing work. They don't get engaged in legislative work, but they're solely focused on preventing kids from using THC.
Yeah. No, I mean that they should, it's insane. And in these small high schools, people think, oh, it's not really like no bang for your buck, but it's like somebody's kid matters, right? Like everybody's kid matters somewhere.
And I would just
Well-
add that she's become just a neuroscientist. She knows so much about it. But also her model is to train high school kids to go out to talk to other high school kids. So she calls it Johnny's Ambassadors because they're out.
No, that's smart because why would you
Great
listen to some 40-something-year-old woman? Listen to the
Right.
15-year-old kid.
Yeah. Yeah. Telling you that
Right.
marijuana is good for you.
Right, right, right. No, I love that. No, definitely. I appreciate somebody put it in the chat. I appreciate it so much.
Right. So I think Leslie and I both we go to Johnny's Ambassadors looking for studies and also learn about SAM, that's Smart Approaches to Marijuana. They're the two organizations that put the studies together that they find. But anyway, this has been outstanding. And I'm just wondering if the rest of you will join me in thanking Amy Swift for being here this evening.
Thank you.
Thank you so much. Yeah,
Really appreciate
thank
it.
you. That was great.
Fantastic job.
Thank you.
Yes, we really
Thank
appreciate you, Amy. You did a great job. You did a great service.
Of course.
Yeah.
Listen, if anyone ever needs anything, the aswift@silverhillhospital.org. Just send me an email. I'm pretty responsive.